Good morning and welcome to the University of Cincinnati Department of Obstetrics and Gynecology Grand Rounds. My name is Elizabeth Kelly. I'm the Executive Vice Chair, and today our Cradle Cincinnati team is thrilled to be able to present to you. We are Meredith Shockley-Smith, who's the Director of Equity and Community Strategies, James Greenberg, who's the co-founder of Cradle Cincinnati, and Ryan Adcock, who's the Executive Director. Our hope for you today is that you learn how to solve a complex problem by using equity, strategies, and an operating structure that will work for you. I'd like to start out by framing what infant mortality is, so you can use this frame during the presentation. First of all, the death of an infant is assigned to the maternal permanent address. A live birth in infant mortality data is defined as any birth, regardless of gestational age, that has a heartbeat or a respiration or movement of voluntary muscle. An infant is described as being born alive and dying before their first birthday if it's used for infant mortality. And the infant mortality rate, which we will be using throughout this presentation, is defined as the number of infant deaths per 1,000 live births. We couldn't be happier to be here with you today. Thank you for inviting us. We're looking forward to telling you a story of a city who loves their infants. And it's a story of conviction. This is a story that came without a playbook. And we look forward to telling you how we moved and when we moved with strategy. In 2011, Hamilton County had the second highest infant mortality rate in the United States. If you were a child and you were born in Hamilton County, you were more likely to die than anywhere else in the United States except one county. We lost 120 infants that year. Our rate was 10.8 compared to a national average of 6.05. But let's look deeper at that data in 2011. Look what was happening to our Black children. They were 2 to 3 times more likely to die than white infants, Asian infants, Hispanic infants of any race. And their rate was one of the highest in the nation. In 2007, there was an infant mortality summit held in Hamilton County, where public health leaders, community leaders, politicians, and community members all came together to try to think about ways and strategies we could fight the scourge of infant mortality in our county. It was about that time that I met a very kind, very smart neonatologist named Jim Greenberg. We came together, we started talking, we started thinking, we started wondering what was going on in our county. We both knew the leading driver of infant mortality is preterm birth, and we both knew about that. Jim had buried or pronounced dead child after child as a neonatologist. He knew the stories of the families. He understood the social determinants. By this time, I had spent more than 2 decades in the community. I had worked in the community. I had walked in the community. I had seen how social determinants affected women and their families. In 2013, the UC Health, combined with Children's Hospital, decided to fund infant mortality. We had been talking for a long time at that time. We were ready. We took the opportunity and decided to move, and we formed Cradle Cincinnati. We used Cradle Cincinnati to look at data, to look at equity. We hired Meredith Shockley-Smith in 2018, a passionate, knowledgeable woman who helped guide us, tell us how to help the Black children to not be dying in our county. Ryan Adcock was the first employee of Cradle Cincinnati. He came with the knowledge that Jim and I did not have. He knew how to navigate the political world. He's a brilliant fundraiser. He brings people together. He talks at their level. He is a passionate man who has helped drive this movement forward. Throughout our time at Cradle Cincinnati since 2013, we have used multiple strategies. We are grounded in data. We address equity. We collaborate with the community. We are always fundraising and we are always communicating. In 2020, Hamilton County had the lowest infant mortality rate in recorded history. We lost 76 infants that year, 20 less than in 2019, and 44 less infants per year than 2011. And for the first time in recorded history, we have a Black infant mortality rate lower than the national average and our lowest Black infant mortality rate in history. We are here today to tell you the story of our strategy, how our strategies changed an outcome with a city together. We're going to walk through 8 strategies. We have other ones. These are the primary ones. We're going to do 2 things with these strategies. One is we're going to give a generic version we hope you can take when you want to start a movement to change a complex medical problem. It could be Candace, Will, and Heather working on maternal mortality. It can be Amanda working on cervical cancer. We'll give you the generic version that we used or the structure that we created. Like I said, there was no playbook. We created a structure. And then we'd like to go through and tell you how we applied this structure to infant mortality. So when there are people out there like you that want to move to another city or want to join us and address infant mortality, you'll know what we thought about and what we did. Our first strategy was our launch. In 2013, Jim Greenberg and I launched Cradle Cincinnati during a perfect storm. Like we talked about before, we had been talking for years. We had been thinking about it. We had been wondering. We had deep and profound experience. We knew the subject matter. Funding came forward, we grabbed it and we moved and we went above the fray. To launch a strategy, you need a problem. You need leaders. We've talked about that. And you need funding. You need seed funding. We had all 3 of those. We had a high visibility problem. Together we had deep knowledge and we had passion. This work takes a lot of energy and a lot of time. You have got to love it if you are going to launch it. Our second strategy was a theory. Like we talked about, there was no playbook. We had a high infant mortality rate. What were we going to do? We developed a theory. Our theory strategy was to look at available research and evidence, to use our knowledge, and to discuss what we would do with the people most affected by the problem. We did all of that. Our theory was that the elimination of infant mortality requires that we acknowledge the intrinsic link between biological and social determinants of health. They have got to come together. And we believe that the health systems were responsible for working closely and tightly with social service agencies and bringing that to life in their home. It was no longer a model where you would send a referral or wonder if someone had gotten something. That is how we started. Next, Our next strategy is an operating structure. We had launched, we had a theory. Now we had to begin to make it to come to life. In this picture, you'll see people that were involved in the movement to address infant mortality. This is at our second strategic planning signing ceremony. In this picture, you'll notice the late Todd Portune, Clarence Polly, Regina Lynch, nurses, community members, politicians, mothers, all coming together still after 5 years. The operating structure we chose very intently gave us a compass at the beginning of our journey. It was very formulated for us. How did we choose an operating structure? How do you choose an operating structure? Research the existing models. Would it be a learning collaborative? Is it a campaign? Is it a network? Is it a wedge and spread? Is it a fishbowl? What works for you? Find the best fit. And then if you can, talk with people who are using that operating structure. We were lucky enough, as we chose a collective impact collaborative, to have Strive in our city. We studied them and learned from them. We talked about before our first employee, Ryan Adcock. Ryan joined us after Jim and I had chose the operating structure and began to make this come to life. I'd like to hand it off now to Ryan to continue the story.
Thank you, Elizabeth. What a gift it is to live in the same city as Elizabeth Kelly. So intelligent and driven, and the shortest version of this presentation today is that we have her with us, and she's led this work for so long now. I've been asked to talk to you all about collective impact, which is, as Elizabeth said, the operating structure that we have used for close to 10 years now. And to do so, I want to back up. In fact, I want to back way up about 170 years and talk about a different issue in our community, which was the prevalence of fires and fire-related death back in the 1850s. And Cincinnati was not unique in that fires were killing a lot of people, causing a lot of damage, and were very common in our community at the time. There was, however, a really serious and dramatic fire at the Greenwood Eagle Iron Works, which used to be where Coffee Emporium is downtown, if you've ever been there on Central Parkway. And in 1852, this building caught fire and caused an enormous amount of damage, spread very far and wide, and killed 11 people, and served as a bit of a line in the sand for our community as something needs to change. And particularly what was struck about it was the incentives that existed to, frankly, disincentivize putting out fires in the proper way, disincentivize prevention of fires. So how firefighting worked at the time was it was entirely private. It was entirely designed for profit. If you were putting out a fire, you were doing so to make money. And so what this meant was that when there were large fires like this, multiple competing firefighting agencies would show up. And frequently they would literally fight, fist fight sometime, in front of these fires, competing with each other for the right to put out that fire and the right to earn dollars. And they would sabotage each other's equipment. And again, sometimes they would literally fight each other to do this. That's what happened with this fire. And what we had there was an entirely broken system, a system that incentivized the wrong things. And in 1852, shortly after this fire, Cincinnati City Council realized this and said something needs to change. So in 1853, Cincinnati became the first home to professional public firefighters in the world. And what this meant was that for the first time, putting out fires, preventing fires was seen as a public good, something that did not need to be done simply for profit, but something that needed to be done for the good of the community. And while that might seem like a small step, making this a public good, what it led to was transformational. And over the course of the next decades, we went from a system that incentivized private organizations to fight with each other to a system that incentivized the prevention of fires. For the first time, somebody was not asking, how do we put out fires? How do we put them out quickly? How do we put them out in a way that makes us money? But instead, there were people asking, what if we could prevent fire deaths? What if we could prevent all of this loss of life, all of this damage? And what that meant was that building codes started to change to prevent fires. New materials, fire suppressant materials were developed. Over time, sprinkler systems were put in, smoke detectors were put in. Firefighters did regular rounds in communities to make sure those smoke detectors were working and that batteries were changed. And you think about all these things that seem very commonplace and seem very much a part of our culture now, that didn't always exist. Because they exist, far fewer people die from firefighting now. So what does this have to do with infant mortality? We can sometimes have a healthcare system in the United States that incentivizes the wrong things. And it's important that somebody be at the table thinking about prevention and not just thinking about putting out those fires. So what we did when we built a collective impact collaborative was we tried to bring together all of the interests, competing and otherwise, in Cincinnati, everyone who had a stake in maternal and infant health, and who could come together to think, what if we prevented infant mortality? What if we stopped fighting with each other in front of the burning building? What if we stopped sabotaging each other's efforts? What if we truly worked together on this issue? What could change? There are 5 tenets of collective impact. You can read all about this, articles in the Stanford Social and Innovation Review and other places. So I won't belabor it, but I do want to go through them quickly. A common agenda, a shared system of data, mutually reinforcing activities across agencies, constant communication, and the existence of a backbone organization. I want to hang out on 2 of these, the first 2, which we have found to be the most important. So the first is a common agenda. What does this mean? This means that we need a strategy. This means that our community needs to be on the same page as to, in this case, what is causing infant mortality, what are the main drivers of it, what are the right solutions to run after. And the reason this is challenging is there are, of course, hundreds, if not thousands of things that lead to a high infant mortality rate in the community. And there are hundreds, if not thousands, of potential solutions. We can't do hundreds or thousands of things all at the same time, at least not well, at least not in an aligned fashion. So we have to make choices. We have to focus. And a common agenda, developing a common agenda for whatever issue is all about identifying priorities and identifying areas of focus. We did so in a way that was incredibly inclusive of the community. Our most recent strategic plan had 450 community members involved in selecting priority areas, and we continue to iterate and listen to the community at every step along the way. The second thing we found to be really important is what's called a shared system of data. When we entered the infant mortality space, if you walked around Cincinnati and you asked public health leaders, what is the infant mortality rate? You would have gotten 4 or 5 different answers. And the most recent answer was about 3 years old. You cannot solve a problem if you do not have the right information about it. And so almost job number 1 for us was to get a really robust understanding of data. And if you fast forward 10 years, what exists now in our community is an infrastructure where I can tell you how many kids died in the past month in Cincinnati. I can tell you what they died from. I can tell you their race, their zip code. And we now have the right amount of information to really run after. And we try to make sure that our partners are armed with that information and that we can make changes to our strategy in response to whether things are working or not. So collective impact is wonderful. We love it. We've found it to be a really helpful strategy. And it's just a start. It's just a start. I think sometimes people can be guilty of reading a 2 or 3 page article on collective impact and getting off to the races and just saying, oh, we've got it figured out. There's a lot missing from the theory. Notably, it's a theory that sometimes prioritizes a top-down strategy, is not as inclusive as it could be, doesn't focus enough on equity or community involvement or community input. So I think what's important to do is to also, as you're reading about collective impact, read about the weaknesses in the theory and try to address them from the start. We don't have any need to be perfectly aligned with what collective impact is. We take the good and we add to it and we add to that, and we continue to be learners within the space of collective impact. So really notably, one place where we have done a lot of iterating on the model is around equity, which is our 4th strategy. And to talk about that, I want to bring to the podium my colleague, Dr. Meredith Shockley-Smith.
I'll start with thank you to UC for inviting us to Grand Rounds. It is an honor to be here. And then I will say equity does not happen in a vacuum. 3 years ago, Cradle Cincinnati, my colleague Ryan Adcock, who was just at the mic, and the founders of this, Elizabeth Kelly and Jim Greenberg, said boldly, racism is impacting infant mortality. And I'll say I've studied racism my entire life, and I have done the work of Black studies and women's studies and taught in that field for a very long time. And it is rare for someone to say racism is real and it is impacting our outcomes. So it is a gift to be working with these people who have said, let's do it. Let's get to work talking about racism. So what you see here in this picture is the first conversation that we had with teammates who were also blown away by the fact that white folks are saying racism is real. And not just race, right? So we want to call out, Black women are having X experience and Asian women are having X experience, but we don't say racism, which is a real reality of behavior and not just what people look like. So in the equity strategy, when I came to the table 3 years ago, and we started to talk about racism, we were very clear that the theory we would stand on would include the data-driven facts. So what is actually happening? So all of the data that Ryan shared earlier in real time, how many babies are dying, what is the race of the baby, what zip code do they live in? We can talk about the impact of what's happening. Then how do we center the people who are having the worst outcomes? We need to listen to them, we need to engage with them, and we need to co-construct the intervention with them. That creates a sustainable intervention that folks will continue to interact with moving forward. And lastly, it's a systems change. So we can have some specific changes and we say, oh, look what happened today, last week, last month. But what we want is a fundamental shift in the way in which people behave and the way in which outcomes happen. So what is the data telling us? In the green line that you see at the top, it is non-Hispanic Black deaths over a 12-month rolling period. And the purple line you see below that is non-Hispanic white. And so what you see is that infant mortality is going down, but that disparity gap, which you see on the plot to the right, persisted. If you looked at this all the way back to the beginning of written history, 1968 was the first year we saw this data reported, you would see this trend persist. And so what it is telling us is Black women are having poor outcomes. And this is why we are focused specifically here at Cradle Cincinnati on Black women. So when I came, I knew that the Community Advisory Board would be essential. It is a theoretical grounding. And so I asked 10 Black women in the city of Cincinnati to gather. And I said, we are going to get to work listening to Black women and centering their voice as we co-construct an intervention for ourselves. I too am not exempt, right? So what we know about this issue is that it is not about economic reality. It is not about educational realities. It is across the board for Black women. And so these 10 Black women said, absolutely, I will show up for this work. And so what does that look like? Sometimes it looks like a gathering. And this is where we break bread and just listen to each other. And so what did they say? They said, I don't feel heard, seen, or valued. I feel isolated and I feel stressed. And so we said, well, what we do about that, we will get to work creating a village of people who will connect, gather together, and we will find every Black woman in Hamilton County, because every Black woman in Hamilton County is a queen and deserves to be at this table as we co-construct an intervention. So we talk about the interventions in the minute level. So we're having gatherings and dinner, and that might look like yoga or meditation. But when we talk about systems change, there are 3 examples I want to point out today that came from these gatherings and women's voices and centering those voices in their leadership. One of them is a system of certification that every hospital system in Cincinnati, and you'll see them depicted here, said yes to. So Black women said, I see these headlines in the Washington Post and in the New York Times, they're just like Black babies are dying and Black women are dying. And I just want to know, like, I feel scared to go to my doctor's visit. I feel afraid to be pregnant. That is unacceptable. And so I know that the work that is happening at Cradle Cincinnati, equity journeys that are happening in hospital systems, and naming racism in general needs to be communicated to Black women. Like, their people do know what's happening and they are working on it. And so the hospital system said, yes, let's turn our data externally. So we're collecting data all the time, but we aren't sharing that with the community and they want to know. And so the badging system for equity includes 4 buckets: infant care, so is baby getting what baby needs at the hospital; mother care, is mom okay? C-sections are the data collection, hemorrhaging, et cetera. Staff care, do I see myself reflected in the staff? Is my OB-GYN Black? Leadership diverse, et cetera. And then community care. If I have barriers, social determinants of health, are you supporting me in overcoming those barriers? And every hospital system said, yes, I will share that data and I will make it visible to our patients, which is a powerful move. So I'm grateful for the collection of folks who said yes. And I'll share one more really powerful change that Black women have led and are benefiting from. So Medicaid, who was a great example of a funder who also centered Black women in their work, and the money that came to Hamilton County for maternal and child health was given to Cradle Cincinnati to prioritize. And specifically, each proposal for that money came through the Queens Village board. So the women that you saw in the picture at the table. And they read the proposals and they prioritized how they felt the money should be spent. And as recipients of those funds, it's a powerful move for them to be able to say, this is something I'm interested in and I feel as if it would work for me, or it isn't. I don't want to fund what will not have outcome change for me. And so that shared power, shift of the way money is spent, is a powerful reality. And I'm going to end by saying that equity is both internal and external. So I don't want to stand here and be righteous in any way. I hold myself accountable and our team holds ourselves accountable to this work as well. So we have an internal team, it's an equity team who comes together twice a month to look at our own strategies. Do we see diversity in our leadership? Do we see equitable pay on our team? What kinds of changes do we need to make in order to have an equitable reality for ourselves? And ongoingly, we walk with our partners and hold them accountable to the strategy that they've committed to. In the picture that Elizabeth shared earlier, when we had all of the folks at the Freedom Center say yes to mortality and the shift in how we will approach it. So as everybody has said at the podium, data is how we march forward and how we know for certain how to create strategy. And to say more about that, I'm going to bring my colleague, Dr. Jim Greenberg, to the podium. Thank you.
Well, thank you, Meredith. And I just want to begin by echoing my colleagues with my appreciation for the opportunity to present our work to all of you this morning. I think my memory may fail me, but I think it was around 1991, late in the year, where I met Elizabeth at an emergency C-section here at the University Hospital. I think it was the first time I attended as a neonatologist here in Cincinnati. It's been a great ride and really, really fun to think about where we started and where we are now. So I'm going to spend just a few minutes talking about data. You've heard that data is really, really important and is really the foundation for everything that we do. So I got to make the slides go in the right direction. There we go. Okay. So I always like starting with this slide. It's one of my favorites and something that really in one picture defines how we think about the problem. You've heard about this fundamental principle of linking social determinants of health with medical determinants of health. And we think about maternal and infant health I always like to think about this pregnant mom who's really surrounded and impacted by a variety of different things. Some of them social determinants, some of them environmental determinants, some of them behavioral determinants. And of course, the ones that we typically think about in medicine, the biological or biomedical determinants, those things like infection and inflammation, genetics even, and so on. So for each pregnancy, we'd like to think that all of those factors have an impact. How much impact and why one factor or another affects a pregnancy and a pregnancy outcome in a certain way is really a fundamental mystery of infant mortality. In order to start unraveling that mystery, we actually need to measure these things, and that's where data comes in. Each of these things in one way or another can be measured, some of them easily and some of them more difficult. But they all are important because ultimately all of these inform a pregnancy outcome. And remember that pregnancy outcome starts with biological events, things like uterine contractions and cervical dilatation and so on, and ultimately determines in this slide whether you have a preterm birth or a term birth, and of course there are other important birth outcomes that we can talk about as well. So data is how we hope to unravel all that. And what I've just shared with you may seem utterly obvious, but a lot of times the things that are utterly obvious are some of the most difficult things to accomplish. So I'm, in the next few minutes, going to just walk you through how we think about it and give you one relatively straightforward example that will hopefully help you appreciate some of the complexity and effort that is put into defining how we think about data and how we use it to think about birth outcomes and ultimately infant mortality elimination. So, heard a lot about this from Elizabeth and Ryan and Meredith, but just to reiterate, our data strategy reflects a lot of principles of collective impact and just some common sense. The idea of data harmonization, that when that data from various sources needs to have definitions for each variable that are understandable and consistent is important. And when they're not, we need to understand what those differences are. I think Ryan mentioned earlier about timeliness of data. One of the things that absolutely floored me when we started diving into this, oh gosh, more than 10 years ago, was the fact that vital records data, basic data about infant mortality provided by the state of Ohio, it's true for almost every other state as well, is often 2 years, 3 years in arrears. So imagine if you were trying to solve a clinical problem and relying on data that was a month old to care for your patient. It makes no sense. And yet that's exactly what we were being asked to do with our vital records data. Timeliness of data is something we worked hard to solve. And as you've heard, we now know in Hamilton County, thanks to partnerships, again, collective impact, collaboration, those partnerships with the state of Ohio, specifically the Ohio Department of Health, and Hamilton County Public Health and the City of Cincinnati Health Department, to get data basically in real time. So if there's an uptick in a certain cause of death, for example, we know about it basically in real time, and that helps us make sensible interventions and advocate for sensible policies because they're timely and relevant. Data has to be transparent. We can't hide it. We want to do the opposite. We want to share it. And we want to, again, share it in real time. Kind of the timeliness really is part of the issue of transparency. But there's no data that we want to hide when it comes to infant mortality. And that includes data relevant to racial disparities. Something that, frankly, people weren't very comfortable about in certain areas of our county when we started doing this work. I believe now they are, at least I hope to think that. Data has to be reliable. When we say the infant mortality rate is X, it sure better be X and not X plus Y. The reliability is a challenge because, as I've just mentioned, we want timely data. And it is the fundamental nature of a lot of public health data that it takes time to make sure it is completely accurate. And really the deal that we've cut, so to speak, with our partners at the state, county, and city level is that while we absolutely are committed to accuracy, or maybe precision is the right word, we want it to be useful. And what that means for us is that there are always a few infant deaths that are hard to figure out and hard to assign, whether they're local or whether they're remote. That ultimately can change an infant mortality rate perhaps from 5.25 to 5.28. But of course, in terms of actionability and so on, it doesn't matter. That number, that difference really is the same when it comes to understanding what we need to do about it. So understanding that our timely data may have to be adjusted slightly, but it is accurate, it's reliable, and it's timely is very, very crucial. And that all leads to data that's useful. And hopefully you can appreciate that that's where we're trying to get to. It seems silly to collect vital records data if we're not going to use it to solve a problem. So how do we, there we go. Well, I screwed up here again. Okay. So I'm going to give you an example, one that seems really, really simple, cause of infant death, and share with you a bit of how we think about the cause of infant death. So this should be really simple, right? You look at ICD-9 codes or ICD-10 now, look at death certificates. It should all be right in front of us. And what that data says is that the leading cause of infant death is birth defects, congenital malformations. And certainly when I was young and promising and studying for my boards in neonatal perinatal medicine for the first time, that was the right answer to that board question. And in fact, I was talking to one of our fellows a couple of years ago when they were studying for their boards. And yes, on their board review information, that question comes up, and this is still the answer. And that answer is correct if one looks at those codes and looks at death certificates, but it's actually way off if you dig deeper into it, especially if you want to think about how to respond to a problem like infant mortality. We took advantage of some really wonderful work led by Eve Lackritz, who was at the CDC in 2005, who actually published a lovely paper looking deeper into this problem and saying, you know what if we looked at cause of death a little differently? Using one example, what if we looked at all of the morbidities associated with extreme preterm birth and ask if they are listed as the cause of death on a death certificate, can that be combined with the death certificate information assigning preterm birth as a cause of death? What would happen? So the thinking here, of course, is that a complication like intraventricular hemorrhage really occurs exclusively in extreme preterm births. And it turns out if you combine death certificate data assigning necrotizing enterocolitis or intraventricular hemorrhage or patent ductus arteriosus with preterm birth becomes the leading cause of infant death. Now, how do we know that? On the slide, you can see that at the bottom here, because I'm doing this fancy animation, I'm going to show you a graph in just a second, but I want to start out by showing you the source of that graph, which is the Hamilton County Fetal and Infant Mortality Review. I'm not going to go into details about how the Fetal and Infant Mortality Review process works, but suffice to say, as the name implies, it is a process that is actually mandated by the state of Ohio to review all child deaths, including infant deaths. And the FEMR, the Fetal Infant Mortality Review process, is a way of doing that, a systematized way of doing that. And Elizabeth and I, early on, when we were in the early days of what became Cradle Cincinnati, appreciated that the FEMR process could be used to understand what we call the FEMR cause of death, the cause of death that actually caused the infant to die, rather than an associated morbidity. And if you do that, it turns out, as I just told you, that preterm birth is indeed the leading cause of infant death, not only in Hamilton County, but nationwide. In Hamilton County, it accounts for more than half of all infant deaths, and most of those are extreme preterm births under 28 weeks gestation, the vast majority. Birth defect-related deaths account for almost a quarter of infant deaths now in Hamilton County. That percentage and that rate has been very consistent for a long, long time. Sleep-related deaths, which we haven't talked about a lot, but are an important contributor to preterm birth, or excuse me, to infant mortality, account for a significant percentage of infant deaths in Hamilton County. And that informed our strategy. We made sure that we emphasized and continue to emphasize interventions for sleep-related deaths in our infant mortality elimination work. So how have we done? Well, we've really, as you've heard, made it a directed, intentional effort to address preterm birth. There's a large strategy with many, many different drivers that we work to measure and think about that include, as you've heard, issues around how we deliver prenatal care and how really important issues like racism, especially systemic racism, impact prenatal care, and many, many others. And happily, we've seen a dramatic decrease in extreme preterm birth in Hamilton County pretty consistently since 2011, but more dramatically in recent years. That, by the way, is going down in large part because Black extreme preterm birth is going down. Because if you do the math, in order to have an impact in Hamilton County, if you don't look at focus on Black extreme preterm birth, nothing's going to change. Our birth defect related deaths have been consistent and have really not varied very much. And that's not surprising, in part because while we work hard to understand what drives congenital malformations and deaths associated with congenital malformations, a significant percentage of these are still untreatable. And when I talk about those, I'm including genetic defects such as trisomy 13. Sleep-related deaths are a different story. We had some initial success, and by 2014, there were only 7 sleep-related infant deaths in Hamilton County. In 2020, there were 21. We believe the COVID pandemic contributed to this, and it's an area of urgent focus for us. So, my last slide, this section, where are we now? We collect a lot of data. And if you think about that first slide that I shared with you of all the different determinants of a pregnancy outcome, we work to collect data that reflects as many of those social, environmental, and medical determinants as we can. And we work hard through data analysis, and collective discussion and thinking to guide our interventions. So with that, and I invite you all to read more and look at our data. This is data that is depicted from our Cradle Cincinnati annual report, which could be found at cradlecincinnati.org. But I'm going to turn it over to Dr. Kelly, I believe, who's going to talk about how we take that data and those interventions and translate them into interventions. Thank you.
I'd like to pause here and reflect. You can probably see when we talked about our strategy of filling in your team, how we all complement each other and come together. It was something really beautiful for me to see as we were rehearsing through this grand rounds. So interventions is our sixth strategy that we'd like to talk about with you today. And it should be very clear by now that every intervention we choose is based on data. Jim talked about the fetal and infant mortality review, and that was started in 2009. And we were given the opportunity as a county to have fetal and infant mortality review because of our high infant mortality rate. And it is something that allows you to look at the death certificates, which are non-discoverable. So you find out the deaths, look at maternal records, look at infant records. The records are given to you. You don't have to ask. It's part of the initiative of fetal and infant mortality review. And we do interviews. And in 2010, I was working as the director of maternal and infant health for the Cincinnati Health Department as a member of the University of Cincinnati College of Medicine faculty. And I began reviewing death certificates. And it's like Jim said, when we started, I was like, cardiopulmonary arrest is on everything. Like, what does that mean? And why are the babies really dying? So when I started looking through the death certificates, something really profound happened. I recognized the names of the mothers. And I recognized the names of the babies. Because these mothers and these infants were part of the Cincinnati Health Department system, where I had a team that went out into the centers. And I didn't cry, but I wept. I wept because they were dying of sleep-related deaths at an enormous rate, 3 to 4 times the national average. And we were not talking about sleep in the Cincinnati Health Department, the team that I was overseeing. So our intervention strategy is one that really brings to life everything we've done. The launch wasn't easy. Jim and I had to present to the UC board. It took a lot of time. We developed a theory. That didn't come overnight. We decided to use a collective impact collaborative. We used equity. We used data. And it all brings you to this intervention strategy or an intervention. Because if you have all that and you don't do anything, nothing is going to change. You can look at data for every day of every second of every day. So our intervention strategy for you to learn from, if you want to go forward and solve a complex problem, is choose. Choose the intervention. Decide where to focus. Design the intervention. The rubber hits the road, execute your intervention, and then evaluate your intervention. Best as you can when you can choose data-informed interventions. If that doesn't exist, which it almost always should, use strong theory. But we've learned through the time, all of us together, that there's lots of people with lots of theories that are not data grounded. And that's a pitfall we've stayed away from. What our data told us, for us in Hamilton County, is that infants and women who access care in the first trimester are less likely to have an infant death, and we're not talking about it, but it all goes together, a maternal death. Our infant sleep environment and position was something that was contributing to death. Most of our sleep-related deaths are infants sleeping in bed with an adult or sometimes a sibling or on a couch, rolling over, getting wedged in between the edge of the couch, and suffocating, or suffocating from someone accidentally rolling over on them. Interpregnancy interval. We've, hopefully Emily DeFranco is in the audience. I can't see the participants, but she knows very well, as her team does, that interpregnancy interval is a very powerful contributor to preterm birth. And you've seen preterm birth as a leading cause of infant death for us. The same thing with maternal tobacco cessation. When we first started looking at the data, 21 to 26% of women in Hamilton County smoked during their pregnancy. It's a big driver of extreme preterm birth and is significantly related to sleep-related deaths. We've talked a lot about stress and social determinants of health. Racism is a social determinant of health. We knew that you can give someone transportation, but if their overlying problem is racism, they don't really need a token for transportation. They need the racism, they need to be heard and seen. So these are the first interventions that we chose. We actually first chose what we called the 3 S's, sleeping, spacing, and smoking, and moved on since then. If we go back here to saying, deciding where to focus, we did decide to focus on systems and the population. The population are the Black women and infants, and as well, the entire population sector for us. We used 2 system level approaches, upstream and downstream. Both of them, you could argue, are upstream, but we have a Cradle Cincinnati policy committee and what we call Cradle Cincinnati Learning Collaborative. The Learning Collaborative is focused on work in the prenatal space. We know that over 95% of women get prenatal care, so it's where we can engage women. But we want to change the system. We want to be sure that every woman is getting tobacco cessation assistance. We want to be sure that every family has what they need to be able to help their child sleep in a safe sleep environment. We have more than 300 prenatal care and social service providers representing more than 18 practices. We consistently engage with the teams in an all teach, all learn model. And that model for us is in the middle of being re-looked at. It's been a challenging one around the quality improvement part. Mike Morawski runs our Cradle Cincinnati Policy Committee, which is a committee that's responsible for research and advocating for policy change. So how can we at a local and state level, as a Cradle Cincinnati Collective Impact Collaborative, affect policy that will change the way women and infants are able to be part of the community and thrive. Here are some of the accomplishments of the policy committee. Mike Morawski and his team have been very involved at a local and state level. You can see from the second one down, the Tobacco 21 legislation. Cradle Cincinnati was intimately involved in having that pass. To reach our population, we decided early on to engage with very rigorous and robust and expert marketing. We were fortunate enough to be able to partner with Desky, a marketing firm. They gave us a tremendous amount of pro bono work up front and still do that to this day. We started out with brand activation. That is, what do we feel like? What do we look like? Everything that they chose for us, the colors, the movement, the flow, all went into how Cradle Cincinnati comes across. They launched an awareness campaign for us, one that did not shame people, but looked to empower women to make changes, to find the strength and beauty that we know is inherent in them. And this was an awareness campaign around tobacco cessation. We also have brand extension around equity. How do we bring the voice of the Black women into the brand? And that was the branding that Dusky did for us around Queens Village. And you'll see the other parts of the brand extension campaign. One of the other things that we've talked about was choose interventions that you can actually do. And if you don't have the resources to do them, either don't do the intervention or decide to fill in the gaps. So at Cradle Cincinnati, we decided to fill in the gaps. You'll see with the black bolded dots, the interventions that we have and the funding that we have to support those. Jim Greenberg and the Cradle team, under his direction, received the first Healthy Start grant in the history of Cincinnati. It's a grant that provides social support to women who need it. We have grants from the Ohio Department of Health and Interact for Health for maternal tobacco cessation, where tobacco treatment specialists are placed in prenatal care spaces. You all know Brianna is here, and she provides our tobacco treatment cessation. Additionally, we partner with Charlie's Kids, Job and Family Services, Hamilton County Public Health to receive funding, again, to fill in the gaps where we want to execute interventions, but there are not resources to do so. Our next strategy is partners. I'd like to reintroduce Ryan to come up to talk about that.
Thank you, Elizabeth. I'm going to close out our presentation with some thoughts on partnership and funding. There are more than 10,000 births in Hamilton County every year. And I'm going to say that one more time. There are more than 10,000 births in Hamilton County every year. I think in the social sector in general, we are very accustomed and have normalized shrinking problems and thinking that if we can help one person, if we can help 10 people, that we can solve these big systems level problems. There are more than 10,000 births in Hamilton County every year. If we want to impact things like infant mortality, we need to be able to reach a critical mass, if not every one of them. So a simple example here is that, yes, here at UC, we should want to make our labor and delivery experience the best, safest, most energizing one for families possible. But we should also be thinking about what partnership with the labor and delivery units at TriHealth, Mercy, and Christ might look like. How do we get better together? How do we learn from each other? How are we transparent and share data with each other? That's what starts to get to those 10,000 births. You can think of other examples around the dozens of prenatal care providers within our county. You can think about ways that we might reach individuals in their neighborhoods. To have success at moving a population-wide metric, we need to be thinking about partnership at every turn. What makes strong partnership? What do we look for in partners? Knowledge, resources, reach, and insight. It's rare that we're looking for all four of these things in one partner, but we are usually looking to invite in partners who have a strength in at least one of these areas. So for example, in the knowledge space, we rely heavily on the Cincinnati Health Department and Hamilton County Public Health, along with the Ohio Department of Health, to help provide data to our collaborative and to help us understand best practice within public health. We have a research committee that helps us grow our knowledge here locally. And we rely on the medical community locally to help us better understand things like preterm birth. Resources. I'm going to talk about funding here in just a moment. We really like engaged funders, and we have lots of them. We think about the public sector as a place where unique resources can be provided. Medicaid managed care plans, healthcare systems locally invest in our work. Reach. We want to get to as many of these 10,000 births each year as possible. So we think about influencers and elected officials, and we have great partnerships, ongoing partnerships with the media who reach out to us for support around stories, and we reach out to them to help amplify the message. And finally, insight, in particular from people with lived experience and people who are closest to the problem. I think about a committee that I was in a few years back where we were talking about a potential policy that we wanted to advocate for around expanding the earned income tax credit here in Ohio. And without getting into all the wonky policy details of what that means, I want to share a little bit about that conversation. I had read about it. I had done my research. I had read proponent testimony and academic pieces around why the earned income tax credit was important. But around that table of people who were trying to influence this policy included a mom from our community, who received money from the earned income tax credit and used it to pay her rent. And there was nothing more powerful in that room than that lived experience of that mom who had actually interacted in the real world with this policy and could help us inform what could get better about it, what could change, how would it be meaningful to her. I could have spent 3 weeks reading about this policy, and it would not have been as informative as the 3 minutes that I spent in conversation with her about it. So we have a tendency to undervalue lived experience, and we want to shift to highly valuing lived experience within partnership. We also recognize that we are not just seeking partners, but we are a partner. So we try to bring these same things to the table. We try to bring knowledge whenever possible, including bringing the latest research to the conversation, including going out and seeking qualitative data and gathering survey information from our community and try to lift the game around knowledge of infant health outcomes in our community. We try to bring resources to the table. We frequently seek out grants where we are one of many who are at the table. And so we bring resources to our community and then divide those resources amongst a variety of partners. Reach, we certainly have a variety of ways that we try to bring to our partners an amplified voice throughout the community, and insight, and trying to bring together people who otherwise wouldn't be in the room together to gain insight around this issue. So if you're forming partnerships, some things to think about: who has influence over the population that you're trying to serve, who could effectively advocate for change, where are those levers of power, who is your dream team. Think big. We have had hospital CEOs say yes to this problem. We have had mayors and county commissioners and governors say yes to this problem. Think about who can make change and invite them into it. Who has a track record of fixing complex problems? Who has passion? Hopefully you've heard that from the four of us today. Who has decision-making authority, and who can help you better understand the problem? Some lessons learned on partnership. One is that you need to constantly communicate, constantly. We think about this through a whole variety of means, and you cannot have partnership without communication. Credit is infinitely divisible. It is human nature to want credit for the participation that you have in a collaborative effort. And I think about some of my most frustrating days around this issue, and they usually have to do with credit or desire to seek credit. And I'll tell you a brief story from the start of Cradle Cincinnati. When we were announcing this partnership's launch, I got a call from not one, but multiple partners that said, I saw the press release. Why was our logo not bigger? Why wasn't our organization's logo bigger than the other organization's logo? And it dawned on me for the first time that if we want to solve infant mortality, every conversation, unfortunately, is not going to be about infant mortality, is not going to be about the center of the problem. We need to deal with the psychology of humankind as we move forward. We need to have conversations, unfortunately, around things like how big my logo was. And so we try to get ahead of these kinds of issues and give out credit as frequently as we possibly can. It truly is a collective effort that's led to this change in our community. And so it's not insincere when we give this credit away. It takes leadership from all around our community to make this happen. Funding can bring together partners, and it certainly is often a catalyst for doing so, but it makes a lousy primary reason for being around the table. We've seen again and again that when somebody is just there to participate in a grant, the motivation is all wrong for continuing in that partnership. It's okay to fire partners that are counterproductive. If you think somebody's going to be a really important partner and instead they are a thorn in your side, get rid of them. They don't need to be a part of the partnership. We don't need to say yes to absolutely everyone who has an interest in the issue. And finally, engage a lot one-on-one in addition to your work around collaborative tables. There are power dynamics at every collaborative table, and sometimes voices that need to be the loudest are the quietest in those rooms. You can get around that by having lots and lots of coffees, lots and lots of one-on-one conversations with partners that you work with. I want to close by talking a little bit about funding. We have, over the course of our time at Cradle Cincinnati, raised more than $30 million in new money for the issue of infant mortality in our community. That's been spread to a whole variety of partners, and it's been invested really thoughtfully. And I wanted to share some of our best practices around that. The key point around funding, if you hear nothing else from me, is that you want to align with the motivation of your funders. So let me talk a little bit more about what I mean by that, by talking about two broad types of fundings that we think about. One is relational and the other is more formal or structured. So relational partners are often local, are highly interested in the big picture outcome. I think about organizations like the Greater Cincinnati Foundation, the United Way, Interact for Health, BI3. And these are folks who are making funding decisions locally, who you have the opportunity to get to know, create relationship with, understand their motivation. And I'll tell you those 4 examples I just gave, the United Way, Greater Cincinnati Foundation, Interact for Health, BI3, they have strategic plans. They have goals. They're highly transparent about them. They are public about them. The United Way just announced yesterday that they are shifting much of their funding to systems change thinking. And so you want to understand those goals. You want to read their plans, and you want to look for places where your work aligns with it. So I saw that change at the United Way, and I said, we think a lot about systems change. There might be some overlap in the Venn diagrams between how the United Way is thinking about the world and how we're thinking about the world. More formal or structured grants, I typically think about, in particular, public sector or government grants here. They're highly interested in process with an emphasis on fair decision-making. We get a grant from HRSA, the federal government, for example. And I would say the key to our success there has been more around attention to detail and things like that. So what are our keys to success? Within the relational space, aligning to what a funder wants to achieve, and including them from the very start. We often have year-plus long conversations with funders before we ever submit a proposal to them. And tell a clear story. This idea of constantly communicating applies to the funding community as well. And with more formal or structured grants, strong attention to detail and an emphasis on experience, capacity, and professionalism, we think have led to success within that space. So with that, I'm going to hand it back to Dr. Kelly to close this out, and then we will gladly take questions and have quite a bit of time to answer this.
Thank you all for the opportunity today to tell you the story of this city and this village. You're all involved in this, and we're grateful for your involvement. There's many of you that sit at the table with us that help us with interventions and well wishes. Thank you. We'd like to also now open it up for questions and ask you, what questions do you have for us? What thoughts do you have for us? It can be now, it can be at any time. We're always open. You can, Michael, they can unmute. You can unmute and ask a question, or you can put a question or a thought or a comment into the chat, and we'll spend the next, looks like 15 minutes or 1 minute, however long it takes, to engage with all of you. Thank you so much.
Elizabeth?
Yes?
Hey, this is Rocco Rossi. Hey, can you speak to what you think I noticed the timing of Cradle and all the things. What impact did Medicaid expansion you think have on the initiatives that you brought about? What impact do you think the Medicaid expansion had on some of these infant mortality rates and everything that you've accomplished in the last 7-8 years?
So the question was,
Rocco, I'm giving this over to Brian.
The question was the impact of Medicaid expansion specifically. And I'm happy to start there. I think as we talked about, policy change is a really important driver of lots of macro public health outcomes. We have seen things like extreme preterm birth nationally shift with the expansion of Medicaid. We've seen mortality improve more quickly. States that adopted the expansion of Medicaid, and I think beyond the expansion of Medicaid, also thinking about other kinds of Medicaid policy are important. So in particular, what does Medicaid pay for? And we are currently in some shifting environment around postpartum coverage for women. Medicaid is currently examining paying for additional services like doulas and community health workers, and we think all of these things will have an impact on the outcomes for our community.
Thank you so much for this excellent talk. You guys are super inspiring. I guess I'm questioning the decrease in preterm birth has been noticed internationally in the pandemic. And there's been a lot of theories regarding that, such as less pollution, less physical movement, less stressors, the moratorium on evictions. Has your team kind of focused on any of these that you kind of thought that you're considering as lead cause? And if so, how, if we ever get so close to pandemic growth, how can we implement these?
I'm wondering if people could hear Heather's.
You should repeat the question.
Yeah, Heather's here. Is the lone person in the audience?
Yeah, so the question, I'll do my best to summarize. It had to do with the observation that preterm birth has declined during the pandemic. Worldwide, at least in many countries, and wondering about why what we've seen locally. Is that fair? Okay. So I'll start, I guess, and I'm sure that Meredith and Elizabeth and Brian have things to add. One of the things that we didn't emphasize from a theoretical, I'm going to go back a little bit here, so bear with me. We didn't emphasize in our talk, but really is worth talking about, is that elimination of infant mortality, reduction of preterm birth are what we call wicked problems. And wicked problems are hour-long discussion in and of themselves, but basically think of them as very complicated problems, hard to define, how to understand. And one of the characteristics of a wicked problem is that when you are solving it, often you don't know why. And I think that's true for infant mortality and preterm birth. Since we still don't understand why babies are born, to be perfectly blunt, in a deep and profound way, at least, we have a lot of trouble understanding why they're born too early versus on time. Although there are lots of theories, and we act on those theories because we can't wait for understanding in order to solve the problem. Hence, another characteristic of the wicked problem. So, infant mortality has improved. Preterm birth, especially extreme preterm birth, has been declining in Hamilton County actually for several years. The graph that I showed made it look as if it was declining consistently since 2011. Actually, the most rapid decline in extreme preterm birth has been over the last, I would say, 3 or 4 years. The pandemic here, I would say, didn't change it dramatically, continued to decline. And it may have declined even more at a faster rate. We can't tell yet for sure. And we don't know exactly why, but there's some interesting qualitative data that Meredith and Elizabeth, I think, can share about what women were experiencing during the pandemic and how that impacted pregnancy, and ironically, how it impacted the pregnancy around issues of stress and racism. So with that, I'll turn it over to you.
Sure, thank you. So as part of the Queens Village work, we are constantly listening to Black women. That was no different during the pandemic, and so we asked what are you experiencing, and so much of what they were saying, and you mentioned some of the social stressors that were happening were less of barriers. So there was a lot of concern around eviction, solves in the medical space, so not having to deal with transportation, childcare, telehealth became much more prevalent. Also, just the dating, so there was a whole conversation about like when I'm in the store, grocery store, I walked into a follow or took away the need to go and solve that problem on grocery pickup, delivery, or what have you. It just felt less stressful. I will say that when school went online, that shifted a little bit because that semester became, now I'm a teacher, what have you, multiple grade levels, et cetera, trying to manage. But I will say that the other thing that folks were saying was, and now I'm very intentional with my time. And so that intentionality starts to create some new solves for your self-care. So those were much of the major comments or concerns that we were hearing in order to do that.
Yeah, it's like a $10 million question, agree. Like, what are we going to learn from this pandemic, and what are we going to learn from the pandemic around preterm birth? What we learned from some surveys that Emily DeFranco and I've been working on for quite a while is that our population at UC and in the community engaged earlier in prenatal care. They came for more visits. They also were more likely to say that they were treated differently because they were Black, that they felt more racism. Now, one of the things that we as a team have reflected on, and I don't know, we don't have answers, or we could probably talk about it for hours, literally, enjoyably, because we love to do that, is the George Floyd murder, and how did that affect the Black population with Black Lives Matter and the freedom and the finally, and Meredith can speak to this, after many, many years of Black Lives Matter, the final, really coming forward with that. And I think how the pandemic and the murder of George Floyd collided is something that we'll be, I think, thinking about for a long time. Do you have any thoughts about it?
You're expert.
David, oh yeah, this is another, you can win $10 million question. You mentioned increasing sleep-related deaths in 2021 suspected to be related to COVID. What are your thoughts on how to address this? I'll start with 2 sentences and then pass it on to Ryan, who thinks about this. We think about sleep all the time, constantly. Since Jim and Ryan and I first got together, the first thing we decided to go after was sleep, because our sleep-related deaths are very high, and now we're catapulted again. The average in the rest of the nation is not this high, so it is something unique in our county that's going on. All of those sleep-related deaths are on the uptick. It's a conundrum for us. We try lots of different things. Ryan will talk a little bit about our newest thought, newest strategy, and newest funding.
Yeah, I can just jump in. I always like interrupting Ryan. There are a couple of things, getting back to data, at least it's some things that are clear. It's become earlier in this century, we didn't see the same kind of disparity, racial disparity around sleep-related deaths that we do now. There's a message there that we need to understand. Also, thanks to the FEMA process, we have a very detailed understanding of how these babies die. And it's, as Elizabeth mentioned during her presentation, but it's worth re-emphasizing, it's co-sleeping, it's sleeping with another adult, or occasionally another child, but typically an adult, and on the same sleep surface. And those 2 things are a big problem. Having said that, I'm going to turn it over to Ryan to tell you how we think we're going to solve the problem, because it is indeed a wicked problem.
Yeah, I've got the same answer I do to everything, which is partnership. So we recognized this trend late last year. We pulled together a group of about 15 partner organizations led by 2 moms in our community to come up with a new campaign and a new strategy around this called the Safe Sleep Is Worth It campaign. You can get materials for your organization. You can learn more about it at Cincinnati.org/sleep. But I think one thing that we've seen over the years work again and again and again is when lots of partners align around, in particular, messaging around safe sleep and really hit it consistently with families, we see these numbers go down. We've seen 3 or 4 waves over the years where numbers go up a little bit. We really put the pressure on, lots of partners rallying on the issue, and the numbers go down. And so we're hoping that can happen again right now. It is Safe Sleep Awareness Month here in October, and I'll give you just a couple of examples of kind of collective action that's taking place right now. Hamilton County Jobs and Family Services, who often are on the front lines of this issue, and are in families' homes after these deaths, have invested this year $250,000 in this year's Safe Sleep campaign for our community. If you drive by their building downtown right now, there's a digital billboard out with a safe sleep message. Healthcare partners are trying innovative things. There's new pamphlets and onesies and t-shirts going out to families. Mercy Health just launched a coloring contest for kids in their healthcare settings that teaches kids about safe sleep and that they can use to plaster up the message on the walls. We have partners reaching out and asking for new tools to reach out to families. We are, I believe, next week doing some door knocking where we're going door to door with this message, leaving hangers on families' doors when they're not home. And so it's this idea of a consistent message from a whole lot of people. If they hear it on the Metro bus, at their healthcare setting, when they drive past the billboard, on the radio from a trusted source, at church, from their neighbor, this is the kind of change that we can hopefully lead to. I think a lot of us, an analogy might be the COVID vaccine campaign. I think a lot of us have been frustrated by the pace of change there, but the reality is that for months now, somewhere between 600,000 and 1 million vaccine hesitant people are getting vaccinated every day. It's an underappreciated win, and I think the thing that is getting us there is consistency and a variety of voices continuing to get the same message again and again and again. Safe sleep or the value of the COVID vaccine might not be a message that lands with you the first time you hear it, but we believe strongly that if you hear it from enough voices, enough times, that behavior change can happen.
Well, thank you all. We are grateful for your participation. Look forward to hearing from you any and all the time here at Cradle Cincinnati. Thank you for being here. Have a great day.